Therefore, they said the gait pattern is still related to to the maturation in this particular system. They said gait parameters such as stride length, step length, duration of swing can vary with age, and actually they do vary with age. The changes in these parameters were closely related to balance, coordination, and metabolic cost. Therefore, when the child has a better, base of support, not working with wide base of gait, not working with excessive lordosis, not holding tight the muscles of the body because of fear, he will now have better balance. And when the work is when the gait is symmetrical, more symmetrical with arm swing, he works with better coordination. Therefore, we are now going to describe the changes that we see in gait of children from the first year up to the 8 years, but in just 3 or 4 slides. Therefore, most children begin to walk independently between 12 and 14 months of age. But some can be delayed up to 18 months of age, most especially those with delayed milestone. And then the toddler's gait within first to 3 years is characterized by a wide base of support. What they are saying is that when your child begins to walk, he does not walk like you that will walk on one foot. No. Can jump on one foot. No. He walks with wide base of support because there is no much balance. Arm held high in guard position, meaning that just like somebody holding his arms to the chest, does not want to fall. High, foot lift during swing phase. Therefore, when the child is walking, one of the leg that is in the swing phase will just be raised high, as if the child is high conducting. Then fat-footed contact. What they mean is fat-footed contact. Most of our children, most especially those that begin to walk between 1 and 2 years, it is only when they're approaching 3 years that they begin to learn some ability to do heel strike when the leg is descending from swing phase. Usually, no heel strike at that particular moment between 1 to 2 years. It's just foot flat, straight. The second thing is they have short, quick, rigid steps. What they mean is that they take very quick steps. Their gait is not as rhythmical as our own. They take faster steps. It's as if they want to run. They take quick, rigid steps. And then they have exaggerated lumbar lordosis and high cadence. Yes, they can take, cadence is the total number of steps you take per second or per minute. Therefore, the high number of cadence is like they can take several steps at once. Therefore, between 1 to 3 years, this is the typical characteristics of what? The gait of these children. Therefore, here we have normal developmental milestone. I put them in this table. We have sitting without support, but the most important thing is that walking independently occur between 12 to 14 months. It can be delayed in children with delayed milestone. And then we should look at, because definitely, even though we are interested in the gait of the baby, if the child does not be able to take steps and walk, then gait does not mean anything to us. Our focus will have to change to making sure that the child is able to take a step and walk before we now begin to talk about gait. Therefore, it's very important. Therefore, you can see around 6 to 7 years or more, that is when the child begins to balance on one foot. Therefore, taking up and down stairs, all these ones are milestones. They are not directly related to gait parameters, but they are important because when some aspect of the gait is being compromised due to pain, due to an active disease process, due to contracture, then definitely some of these particular milestones might not be achieved in some of these children. Okay, now toddlers from 1 to 2 years in the early stage of gait adopt a high guard posture. We have said it, holding onto the muscles, most especially of the chest. And remember, we said they can easily co-contract their muscles just to be able to maintain balance. They said upper limbs are raised above the shoulder when walking. Therefore, or not above the shoulder, it may be around the shoulder. so as to guard from falling. They maintain stability by enlarging the base of support. We have said it. The initial ground contact may vary from heel to toe, whole foot, or toe to heel. But actually, in children from 1 to 3 years, it's usually whole foot. There is nothing like heel strike. They typically will work with what? Straight knee. Therefore, try to bend the knee a little bit during heel strike before mid stance does not occur, and with a wide gaze of support, as we said. Then let's look at this illustration here. Here, this is Gait in 1 year old. You have flex elbows. You have no arm swing at all. And then remember, look at the heel strike is flat foot all through. Remember, we said they take very high, the cadence is very rapid. They take a rapid number of steps, and wide gait of support with a lot of lordosis. You can see as the child is moving, you can see the body is becoming lordotic. Then we now move at gait development between, what do you call it, at 3 years. What happened? After several months, they gradually develop position of middle to low guard position by lowering their arms. As the child is walking, approaching 3 years, that guarding, raising the arm, contracting all the muscles in the trunk is very relaxed. The child will now be able to bring the hand low, even if it is without reciprocal swing. But at least that high guard position of raising the arm is no more there. They said, gait maturity develop gradually during the first 3 years of life through series of phases, and what alternating arm swing is seen. Meaning that around 3 years, when child has left 1 to 2 years, then you now begin to see evidence of little, what do you call it, development of arm swing. They say the adult pattern of heel to toe gait develops around 3 years. Therefore, when the child is at 1 year, it's just foot flat, straight, when during heel strike. But around 3 years, the child is supposed to develop ability to do some little heel strike before what do you call it, the toes come down. In this particular picture, you can see a 3-year-old, there is little bit of arm swing. There is no that upper limb guarding, and you can see heel strike. You can see around the mid stance. You can see the heel off. You can see the toe off. Therefore, this is important. The gait will change definitely with time. Then it is probably part of what we have to look at when somebody comes and he asks fair with this, the way the child is walking. They always say, no. This is 1 year. By the time the child is reaching 3 years, then the gait, the wide base of support supposed to reduce, the lordotic posture supposed to, the high guardian supposed to reduce, and then you now begin to explain to him, then probably that anxiety will go. Now, we past 3 years now, we are approaching from 4 to 8 years. What happened to the gait? They said at 4 to 6 years old, child can easily balance on one leg and hop. Go back to my previous picture, you will now see hopping takes place around 4 to 6 years, some say 5 years, some say 4 years, but it's around within that range. They said changes to velocity and cadence continue up to 7 years, meaning that ability of the child to walk fast will definitely improve gradually up to the 7th year of age. As he becomes taller, as his muscles become stronger, and as the skill of walking become more perfect without base of support, then he tends to walk what? Faster? Yes. And what they said is when the gait improves, then the cadence, that small what do you call it, steps will now begin to reduce. The child will now begin to what? Cool down. They said mature gait has a reciprocal arm swing, meaning that at this age of 7 to 8 years, 6, 7, 8 years, the child is supposed to have these characteristics of mature gait in children. There must be reciprocal arm swing. There must be heel strike with increased velocity, cadence. There must be improved step length. There should be, what do you call it, improvement in single stance time, meaning that the child will just be able to bear weight on one leg fully when he is walking, and the ratio of pelvis span to ankle spread when both feet are on the ground due to increased stability of the limb. What they are saying is when the ratio of pelvis span to what ankle spread. Therefore, most especially we should know that what they are talking about is the spread of the two ankles supposed not to be very wide. When the gait is good, then the spread of the ankle is supposed to be very close, not very wide. And that is due to increased stability. The child now does not rely on his vision very well, does not rely on wide base of support very well. The movement is reciprocal, and the movement is like it has become automatic. The child has become used to it. The skill has been learned very well. Okay. Then now we have, this is mature adult gaits. You can see the reciprocal arm swing. You can see no more lordosis. You can see the body is fully relaxed. The child is looking forward, not looking at the feet. No more looking at the feet anymore. Therefore, that is maturation of gait, 7 years and above. Then now the next we are going to look at is leg and foot alignment. For us to have a normal gait, then our legs should have good alignment. Our foot should have good alignment. So also that of the children we manage. But there are other normal variation that we see in leg and foot alignment that we thought they are pathological, but actually they are normal physiological gaits that changes as the child grows. The changes might be due to maturation of either neuro or musculoskeletal system, most especially that of your tendons, ligaments that support some of these joints, and the muscles. Therefore, the first we are going to look at is normal foot alignment. We said in toeing, internal tibial torsion, and toe walking. Is toe walking always wrong? Is in toeing always abnormal? They say no. That is why we have the heading, normal foot alignment, that varies with what? Age. In toeing. When one is walking, let me show you this. This is, with this picture, this is what we call in toeing. This is in toeing. You now see the tip of the two legs, the 2 feet are facing each other. That is in toeing. We have persistent femoral anteversion and we have tibial torsion. That brings about what? What do you call it? In toeing. It's due to persistent femoral anteversion, meaning that movement of what do you call it? Rotating of the femur, what do you call it? Towards the midline. It's characterized by the child walking with pattern leg and feet pointing towards inwards, common up to 3 years of age. What we are saying here, it is very common to see children walk this way, with the 2 legs, with the two the big toes almost pointing at each other. They said it's normal up to 3 years of age. Some may be normal up to even more than 3 years of age, but they are saying up to 3 years of age, it shouldn't give anxiety. Because when the child learns to walk this way, definitely the gait may not have that heel strike that you want and everything. But the issue is, this is normal up to 3 years of age. They said internal tibial torsion is also accompanies what you call is one of the cause of what in toeing. Two are the 2 causes of in toeing are the persistent femoral inversion and the internal tibial torsion. As you can see in that picture, the 2 are what? Pointing inwards. Therefore, the legs turn inward. The child walking with patella facing forward, and the toes pointing what? Inward. It's the same thing. All of them, the toes are pointing inward. They said common from the what? Onset of walking to 3 years also. Then they said habitual toe walking. Okay, let's look at this picture. You can see this is what we call in the other one. You can see toe in when the toes are facing each other, toe out when the leg is like facing out. It's very common with crouch gait in children with cerebral dysplasia. It's very common with crouch gait, out toeing. Then you can see in this particular picture, you can see we have internal tibial torsion. You can see the torsion is not only that of what? The femur. It is even the tibia is also what? Turned inward. Therefore, that is tibial torsion and what? Femoral anteversion. They are cause of what? In towing. They said in towing will disappear. It is only when it becomes persistent that we now begin to look at, okay, what is the problem? We now assess, and the orthopedic people will assess. Then now the next is we want to look at habitual toe walking. They said it's common in children up to 3 years, meaning that it shouldn't give, when the parents have anxiety, then the physiotherapy should allay the anxiety. That no, according to literature, that your child can walk either unilaterally or bilaterally with what? On toes. Therefore, some children do that. They do on toes, they walk on toes, but they say this toe walking is common in young children up to the age of 3 years. Then after which, if it is not what do you call it, corrected, then the therapists can come in. Now, out toeing, we have seen the picture showing out toeing. Is the lateral rotation of the foot relative to direction of walking. If the direction of walking is facing you, then the leg will be facing another way, will be facing outward. It is common in infants when they first start walking, but usually resolved within 1 year. There is something that we have to understand. Remember, they said in towing resolves within what? 3 years. Out towing resolves within what? 1 year. Out towing. Now we have what we call metatarsus adductus. It's characterized by flexible C-shaped lateral border of foot, are resolved by the age of 6 years. Then what is this metatarsus adductus? This is what we have here. At times it's easy for you to see children with the leg this way. The leg is C-shaped. This is metatarsus adductus. They said it will resolve. Metatarsus is characterized by flexible C-shaped lateral border of the foot, resolved by the age of 6 years. Then when a child is having metatarsus adductus, then what is the usual position of the tibia and femur? Meaning that it's very possible the child with metatarsus adductus is going to have persistent, tibial torsion and femoral anteversion, because they are turning in, and the legs are likely going to turn into C-shape. Are we together? They may likely go together. Therefore, metatarsus adductus out towing, resolves within a year, and metatarsus adductus may resolve, meaning that even when the child is having internal tibial torsion and femoral anteversion that corrects within the age of 3 years, if they result in metatarsus adductus, this may persist up to 6 years, but physiotherapists can come in such that it does not go beyond 6 years. Then we now have normal age of genu varum and genu valgum. Is it always that the orthopedic physiotherapist or the pediatric physiotherapist have to correct genu varum or genu valgum in a child with a growing child? No, they said genu varum, that is bow legs, are common from birth to early toddlerhood, meaning that early toddlerhood within the first 2 years, not up to 3 years, often without out towing. They said it resolved by 18 months or 2 years, meaning that when a child starts to walk and you see some little bow leg, they said it resolves by the age of either 18 to 18 months or 2 years. Then they said vigenu valgum, or what they call knock knees. They said develops within 3 to 6 years before straightening, meaning that when genu varum occurs at birth, and you begin to now see it mainly prominent when the child begins to take some steps. Genu valgum is as a result of increase in weight of the body. When the child is becoming heavier, taking food very well. Therefore, normally they said due to laxity of joints, surfaces, laxity of ligaments and tendons, they said it develops in 3 to 6 years before straightening. If associated with in-towing, it resolved by 7 years. Meaning that knock knee can be associated with in-towing. And they said it can resolve by the age of 7 years. Meaning that it does not occur at birth. It occurs within 3 to 6 years, but it will come and straighten. And they said this may be due to ligamentous laxity and that it gets corrected as the child improves, as the muscles and joint become stronger. That is for the ones that are normal. Remember the heading normal variant of what? Leg and foot alignment. They are normal. Therefore, we shouldn't have a big problem. Probably when the child is approaching 6 to 7 years, we might put a brace that would ensure that the leg is now straight. Now, yes, but actually, they said it resolves. Then the next is flat feet. Flat feet, or what we call flat foot, if it is one leg, on one leg. Actually, there are three types of flat foot. We have the normal physiological flat foot. We call it flexible flat foot. That one resolves on its own. Then we now have pathological flexible flat foot. Remember, we have flexible flat foot, we have pathological flexible flat foot, then we have rigid flat foot. Therefore, pathological flexible, flat foot is in the other section of our lecture, where we are going to look at pathological gait patterns that are not normal. Therefore, we are now looking at the normal, physiological flat foot, or what the normal flexible flat foot. They say it occurs as part of normal development. Babies have no detectable medial longitudinal act. It is obscured by fat until the onset of walking. It is very common. Let's go back to see our small children. When we give birth to our, neonates. At the neonatal period, when you touch, there is no arc in the foot. That place is filled with fat. They will continue like that. You will only begin to see signs of arc, probably when they begin to take some steps. But they still walk with flat foot. They said the medial arc typically appears within 2 to 3 years, meaning that the first 3 years of age is very crucial to some of these, developments. They said flat feet usually resolve by the age of 6 years. If the child continues to have flat feet past the age of 6 years, then it's abnormal. Then they said, how do we now test? There is a test they call Jack's test. Jack's test for flat foot. What does it entail? If you want to test physiological flat foot, you ask the child to stand on his toes. When the child stands on his toes, then the medial longitudinal arc will appear. Then if it appears, then meaning that this is a flexible flat foot. Or you now pull or strengthen the big toe. If you pull or strengthen the big toe, as the child sits with the leg flat-footed on the ground, then the medial longitudinal arc will appear. Then if it appears, then it's a flexible flat foot. It's going to, when the ligaments become strong, then the child is going to maintain his, medial longitudinal arc. They said, when the child is on non-bearing posture, you ask the child to stand on one leg and raise the other leg. Then the leg that is raised, since it's no weight bearing, when you observe, most especially around 3-4 years, that is when the longitudinal arc is fully, is becoming fully developed. Then you now see it visible. When the child is not standing on the leg, you ask him to raise one of the legs. We now see the arc. We say, okay, it's like, flexible flat foot. 3 tests. One, where we have the Jack test, where you pull the great toe, or you ask the child to stand on his, 2 toes. Then you now see the arc. Or you now ask the child to stand on one leg. Then the leg that is being raised, you now see the arc. This is for flexible flat feet. By the age of 6 years, then it's supposed to have become very strong. The medial longitudinal arc is supposed to remain permanent. Now, the next thing, we are going to look at pathological lower extremity and foot deformities. Now, remember, everything that has to do with deformities in either the leg or foot resolves within 6 years. Everything past 6 years, then there will be problem. Okay. Then remember, we said, like, for example, the genu varum, the child may be born with it, as in physiologically, and then it may be apparent when the child begins to walk, but it resolves gradually. Then we now said the genu varum up to 2 years. Okay. Then the genu varum and the genu valgum is another variant of the knee issues, related issues. But one thing with it is appears within the age of 3 years. And then they said it's as a result of also the joint laxity and plus when the child is adding weight. But they said it resolves within and it's straightened within 3, 4, 5 years. By the end of 6 years, it has to resolve. If not, it has become pathological. Then the child has to be what do you call it, treated. Then pathological lower extremity and foot deformities, pathological flat foot. The pathological, the three, we remember we talk about three types of flat foot. We said there is the flexible flat foot, the normal physiological, and then we said there are other two that are pathological. We say pathological, what do you call it, pathological flexible flat feet, and we said we have what do you call it, the rigid flat feet. The pathological flexible flat feet may be associated with activity-related pain and nocturnal pain. Therefore, when a child is walking and as he walks or he stands for some time, he is telling his mother that his leg is paining him around 3, 4, 5 years of age, and probably when the child is sleeping, he will be complaining that that area of the leg is giving him pain. Then there should be further assessment. X-ray should be done. Some assessment should be done. It's likely going to be pathological flat feet. Then we have rigid flat feet. Examination relieves. Rigid flat feet actually is caused by fusion of some joints in the leg, in the lower leg. The first joint is calcaneonavicular joint and talocalcaneal joint. Therefore, when these guys become fused, then we now have what we call the rigid flat feet. Therefore, what they are saying is rigid flat feet, what do you call it? There is existence of flat feet despite grade 2 extension. The most important thing is we should note that the pain, what do you call it? We should know that rigid flat feet is also associated with that what do you call it, leg pain. And they said for children between the age of 12 years, when this cartilaginous coalition begin, when ossification begin at the calcaneonavicular joint, then between the age of 12 years, some children will now begin to experience this pain. Or between the age of 12 to 16 years, when the talus and the calcaneal are coalescing, as in they are fusing, then some of these children will now begin to feel pain. Meaning that in some, if it is calcaneonavicular coalition, fusion, then or what do you call it, friction, then the pain is felt within the age when the child is aged to 12 years. Then if it is talocalcaneal, what do you call it, friction and fusion, then it should be between the age of 12 to 16 years. Therefore, it may not be fusion like arthrodesis. There may be movement, but that coalition does not allow free movement. That is what brings about the rigid, what do you call it, flat feet. Then pathological genu varum and genu valgum. They said the pathological causes of genu varum majorly include blunt disease. There may be genetic, what do you call it, dysplasias, and maybe there may be some growth plate injuries that may occur in some children. Therefore, what happens is the medial aspect of the epicondyles will erode. That is in genu varum. They will erode such that the lateral aspect will bulge outside, the medial aspect will now, what do you call it, fall inside. Then we now have what we call the bow leg. Blount disease is a knee deformity of unknown etiology common in overweight African American children, exacerbated by what? Excessive weight. They said radiograph may show varus deformity. And now the proximal tibia, that is the tibial plateau that is facing each other, and metaphysis of the medial arc may break. Therefore, what they are saying is when the metaphysis of the medial condyle breaks, then the medial condyle will collapse down, then the leg will now bow. This is what they are saying here. Look at the picture. You can see the shin bone, you can see the other one. Then if the metaphysis of the bone breaks down, then the condyle will point inward and then the leg will bow. The most important thing, this is bow leg. And usually one cause of it is what they call blunt disease, and is of no unknown, what do you call it, etiology. But they said it may be as a result of genetic dysplasia, it may be as a result of some growth plate injury, but the most important thing is the medial condyle is eroded. Then we now have genu valgum, or what we call knock knees. The children may walk with the knees rubbing each other and their ankles pronated. Here is like, this is purely orthopedic. There is a neurological case, like what do you call it? Seizuring gait in a child with CP. It's almost similar. But the one thing with seizuring gait is one leg will go over the other one. But this one, the legs would one will not go over the other one. They will almost meet in the midline. They may rub, but one will not go over the other one. In seizures case, and one cause of this genu is what? Anteversion of what do you call it? Femur. They said they may be associated with inward femoral what? Torsion or outward tibial torsion. They said it is measured by intermalleolar distance when the patient is standing upright with knees touching. The distance more than 10 to 15 centimeters is considered pathological if it is progressive. Meaning that when the child sits, you now look at the medial and the two medial malleolus, then the distance. If it is progressing, if the distance is increasing, then they said it's pathological. The causes are varied from skeletal dysplasia to fractures, like then they said infection or tumors of the bone. They said it can occur also in metabolic bone disease such as rickets. Therefore, when the child is having rickets or osteomalacia, or rickets most especially, what they call deficiency of vitamin D, the bone become brittle and can assume what they call it, this deformity. Then we now have foot deformities, especially because we are talking about children now. We said foot deformities, specifically the children with CP. We have pes equinox, pes varus, and pes valgus. Then pes equinox, pes varus, and pes valgus. They are very common in children with CP. We said pes equinox. Equinox means plantar flexion in stance phase. Just like you standing on one leg flat foot, the other leg on top of the, what do you call it? The toes. That is pes equinox. They said ankle plantar flexion during gait. Let me give you, this is pes equinox. And it's very common in children with either hemiplegia or diplegia. Therefore, this is pes equinox. This is what we are describing. Ankle plantar flexion during gait is due to gastrocnemius or soleus what? Spasticity. They said there are two types. We have what we call dynamic equinox, and there is what we call what? Static equinox. Dynamic equinox occur during walking, secondary to gastrocnemius what? Spasticity, meaning that when you stretch a bit, the equinox will go. Static equinox is due to shortening of what? Tendon Achilles. Therefore, if somebody is having static equinox, walking on toes, it may be as a result of what? Tight TA. At times, some of these children may need what you call it, surgical release of the tight TA. Okay, they say child with pes equinox bears weight on metatarsals. Therefore, as you can see in this picture, the child is bearing weight on his metatarsal bones in the leg. Then we have pes varus. This also occur in children with most especially hemiplegic gait. What they do is they walk on the lateral margin of the foot. Let me show you. This is pes varus. Yes, there was a child I managed with hemiplegic CP. She walks on the lateral, what do you call it, margin of the foot. This is what we call pes varus. Pes varus. And it's as a result of spasticity of some muscles that cause dorsiflexion. Okay, we have, it is due to tibialis anterior, fibularis posterior, triceps serous spasticity with peroneal muscle weakness. Tibialis anterior spasticity cause hind foot varus. Remember the dorsiflexors in our legs. We have tibialis anterior, fibularis tertius, extensor digitorum longus, and extensor hallucis longus. Tibialis anterior is the major dorsiflexor of the leg. Then we now have extensor digitorum longus following. Then we now have tibialis posterior spasticity hind foot varus, while tibialis anterior spasticity causes midfoot varus. Pes equinox is usually accompanies pes varus. Pure varus is relatively rare. They are saying that some children with pes equinox that walk on, what do you call it, on metatarsals, may work on either the small toes of the leg, but still tilting the leg up a little bit. Maybe a combination of both equinox and what? Varus. But this is a true varus, you can see in the picture. True varus. Then we now have pes valgus or pes planovalgus. Please, one cause of pes valgus is what you call, is associated with crouch gait. Crouch gait is common in children with cerebral dysplasia. We are going to see it when we reach the picture. I think this is pes valgus. Pes valgus is very common in children with what do you call it, cerebral dysplasia. You can see pes valgus. Therefore, the what do you call it, the malleoli, the medial malleoli is facing inward very, very well. Therefore, pes valgus, as you can see in this particular picture, this is pes valgus, and it's very common in children with crouch gait. And then what are these, what do you call it, causes of pes valgus? One cause of the pes valgus is untreated pes planus, most especially in children that are having pathological, what do you call it, flexible flat feet. The medial longitudinal arc, instead of descending, it will also protrude inside. The medial longitudinal arc will not only descend, but what? Protrude medially. That is it. Extreme laxity of what? The joints in the foot is one other cause of what? Pes valgus. Then we now have abnormal pathological gait patterns in children. Abnormal pathological gait patterns in children. Yes, when we said gait should be normal, then if it becomes abnormal, then we should be able to spot it. What are some of the abnormal gait patterns that we see in children? The first one is what we call toe walking gait. Now, remember we have seen pes equinox in children with CP. And remember we have talked about toe walking in children, but we said it resolves. Now, we have another toe walking gait we call the equinox, with absence of what? Heel contact. If it occurs in a child with CP and unilaterally, it has become what? Pes equinox. But we have children with that have what we call idiopathic toe walking. And idiopathic toe walking, they say, is a persistence of toe walking after the age of 2 years in healthy children without any neurologic or orthopedic diagnosis. Meaning that when you have a child without any neurologic or orthopedic, what do you call it, diagnosis, nothing is wrong with the child, but he prefer to walk on toes, then this one is called what? Idiopathic toe walking, most especially if it persists more than 2 years. Then now we have, they said one of the causes of it is relative shortening of the soleus and gastrocnemius. They are the ones we call triceps surico. Gastrocnemius, soleus, muscles, and plantaris are what they call what? Triceps surico. When they are very spastic, they can lead to what? Toe walking. And then they said being also accompanied by what? Tightening of Achilles tendon. Then they say it can also be observed in children with what do you call it, upper motor neuron lesion, like hemiplegia, when we see pes equinox, and it can also be seen in children with what do you call it, diplegia. They said commonly associated with limb length discrepancy. Therefore, if one is having unilateral toe walking and there is no neurological affection, they say we should look for limb length discrepancy, short leg on one side. It is likely going to cause what? Toe walking on the other side to compensate for the loss of length. Then they said a dislocated hip or neuromuscular problem. You can have a dislocated hip, can be a cause of toe walking, and then children with what do you call it, neuromuscular problems such as muscular dystrophy. Remember, children with Duchenne muscular dystrophy walk on toes. Therefore, they are also part of what one should assess. And then remember, if a child comes with what do you call it, with Duchenne muscular dystrophy, if he walks on toes, one thing we should observe is that the child will have very what you call pseudo hypertrophy of the calf. The calf muscle will just look as if it is that of an adult. The calf muscle will be hypertrophied, and most especially these guys will have very what do you call it? The children will have very weak trunk muscles, most especially in Duchenne muscular dystrophy. They are also likely going to experience serious delay in walking. The history will tell you that the child has delay in walking. They are likely before starting to walk, exhibit what you call Gower's maneuver. In Gower's maneuver, the child will spread the two hands and the two legs on ground, then begin to draw the hands backward, holding onto his body before he stands. Then if that is the case, then the toe walking is as a result of Duchenne muscular dystrophy. Then we now have some gait patterns that are commonly found. Yes, thank you very much. There is I there is a message I saw under that somebody says children with autism also develop toe walking. Yes, actually there is what do you call it? Children with clumsy gait can also develop toe walking. Yes, there are some psychological toe walkings also. Therefore, we try as much as we could because this lecture will not afford us to say everything. But actually, I agree with you 100%. Some children with what do you call it? Autism, which is a multifactorial disorder. It has both genetic and environmental factors that predispose to it. Thank you very much for adding what do you call it? Autism to it. Okay, get patterns that are some common in children with. Hello. Yes. Some of our members are not muted. Some of our members are not muted. Okay, can we continue? Then we have gait patterns in children with cerebral palsy. We have diplegic gait, we have hemiplegic gait, we have ataxic gait, and we have what do you call it? Seizures gait. We have seizures gait. Then now we start with diplegia. Okay, the heading is supposed to be cerebral diplegia. This is cerebral diplegia or diplegic gait. Okay, what is this diplegic gait? We should understand that it's the name comes from the condition we call cerebral diplegia. In children with cerebral diplegia, the two legs are more affected than the two arms. Usually, let me take it this way. This is the way it is being classified. You have hemiplegia, where you have one side of the body is affected, where upper limb is more affected than the lower limb, and that is what we call hemiplegia. Then we now have diplegia. In children with this, what do you call it, cerebral diplegia, what happened is both the four limbs are affected, but actually the two lower limbs are more affected than the two upper limbs. But if you check the two upper limbs, also they are not very strong compared to a normal child. But the two lower limbs are more affected than the two upper limbs, and it's asymmetric, meaning that the strength of the the foot, the strength of the two lower limbs may not be the same. That is cerebral diplegia. Then we have what they call double hemiplegia. A child that has all the four limbs affected, but the two upper limbs are more affected than the two lower limbs. And then asymmetrically, because you will see one side being stronger than the other side. One side, meaning that the leg and arm on the left side may be stronger than the leg and arm on the more affected side. Then that is a double hemiplegia. Then we now have the quadriplegia. In quadriplegia, what we have is The two arms and the two legs are affected almost equally, and the trunk is also affected. Usually, it's part of the severe what do you call it, form of CP. Usually the causes of what do you call it, quadriplegia is a mixed type of CP where you have both pyramidal and extrapyramidal form of CP coexisting in the same child. Therefore, we are talking about cerebral diplegia. In these children, the two legs are more affected than the two arms. It is characterized by stiff knee in swing phase, excessive knee flexion, and intowing with excessive hip, what do you call it, hip flexion and equinus. Okay, now let me show you in diplegia. This is okay. Look at the picture of diplegia. You can see in one of the leg. Look at the one of the legs around the what do you call it, the ankle, the medial ankle. He has what we call genu, what do you call it, pes valgus. It's not just this. This is past what do you call pes planus. The medial longitudinal arc has what? Gone down and protruded inward. That is pes valgus. And then when the child is trying to walk, you can see trying to almost walk on the ball of the on the metatarsus in one of the leg. It is also that is why they call it what do you call it? Some of them will have some little level of toe walking. But the most important thing in these guys, you look at the hip is flexed, the knee is flexed, and the ankle joint is what? Flexed. And the child will not be able to stand because of tightness of the hamstrings. That is cerebral, that's crouch gait. Crouch gait is used to define cerebral what? Diplegia. Okay. Now, they say diplegia characterized by stiff knee in swing phase, excessive knee flexion, toe in what do you call it, intowing of the toes, excessive hip what? Flexion with equinox. You can see the equinox here. They are telling you that when the child begins to live, it's as if he works also on little bit on the toes. They said F-O-U-R. 4 diplegic patterns we are described. We have what you call the child may start with true equinox. Yes, true equinox. Okay, please, let me explain this. There are 3 variants or 4 variants of diplegic gaits. There are some that are present in younger diplegics. When a child is young, within the age of 1 to 3 to 4, the body weight is not much. The child will exhibit what we call jump gait. That is where you now begin to see true equinox. Then the jump knee. Then you now have, when the child now become old, the body has become what? Heavy. Then the child will now develop what we call crouch gait. By the time the equinox is gone, the heel of the foot has already descended, it's now touching ground. Then both the hip, the knee, and everything are what? Are flexed. Then the child will now develop crouch gait. That is when the child will develop apparent equinox and true crouch gait. Okay, now let's see the true equinox. True equinox gait. They say it's characterized by ankle plantar flexion throughout the stance phase. Ankle plantar flexion throughout the stance phase. Look at this guy with jump gait. You can see ankle plantar flexion. We said the first 2 are coexisting in a child with jump gait. That is a true equinox. Ankle plantar flexion throughout the stance phase. Hip and knee are extended, related to spasticity or contraction of the ankle plantar flexion or weakness of the ankle dorsiflexus. The most important thing is in equinox gait in this guy, the first, most especially in young diplegic, they start with what? Walking on toes with slight flexion of the knee and hip. But they have not reached what we call the stage we call what we call it jumping gait. The next is when the weight is becoming heavier, then the hip and the knee will now become what do you call it more flexed. Then the child will develop jump gait. Then when the hip and knee are more flexed, most especially the ankle is more flexed, then the child will develop crouch gait. Here they said here we begin with hips and knee extended, but remember there is equinox at the ankle related to spasticity or contraction of what? flexors of what? The ankle joint. May present with compensatory genu recurvatum. Then when we now move to jump gaits, remember if we go back to this one, the hip and knee are extended, but there is equinox, and usually in both legs. That is the beginning. Then when you come to jump gait, now the hip and knee are flexed, and the ankle is also flexed, but not fully flexed. Then that is the jump gait. Okay, they said almost all the diaplegic syndrome begin working with a jump gait. The jump gait is defined as excessive hip knee flexion with equinox in stance. The cause is lower extremity flexor muscle spasticity. Child works with hips and knees in flexious, ankle in what? Plantar flexion, looking like athletes that is ready to jump. There is an anterior pelvic tilt and increased lumbar lordosis. Therefore, here, this is a typical jump gait. We have another picture. We have ankle in plantar flexion. But remember, ankle is in plantar flexion and also flexed. We have the knee flexed. We have the hip also what? Flexed. The hip is not extended like in equinox gait. In equinox gait, the hip is what? Extended. The knee is extended, but the ankle is in what? Equinox position. Then we now have the crouch gait. Here in crouch gait, it occurs in older diplegic, in patients that are, older, 7 to 10 years to 15 years, older diplegic. It is defined as excessive knee flexion throughout the stance phase with dorsiflexion of the ankle joint. Observe, in jump gait, you have plantar flexion of the ankle joint. In equinox gait, you have plantar flexion of the ankle joint. The only thing that is in equinox joint, the hip is extended. In jump gait, the hip is what? Flexed. The knee is flexed, but there is plantar flexion. But in crouch gait, the knee, the hip, and the ankle joint is in what? Excessive dorsiflexion. Then they said pes valgus generally accompanies what? Crouch gait. Then they said common cause of crouch gait is what? Short or spastic hamstring, excessive hip flexion, and excessive ankle dorsiflexion. Therefore, you have it. Now it is no more jumping gait. The ankle is not in plantar flexion, it's in total dorsiflexion. You now have the hip is flexed and the knee is flexed. This is crouch gait, not a jumping gait. Hamstring tightness causes crouch gait and short step length when walking. When sitting, tight hamstring pull the tibial tuberosities until the pelvis posteriorly, causing kyphosis and what? Sacral sitting. Therefore, when these children sit, remember the hip is flexed, the knee is flexed when you sit them, except if you want to sit them on a high sitting on a couch, there will be what? Sacral sitting. Then we are going to talk about hemiplegic gait, or what they call circumduction gait. Yes, hemiplegic gait actually occur most commonly in children with hemiplegic CP. It occurs in children with hemiplegia secondary to sickle cell disease. Sickle cell disease. Hemiplegic gait also occur in children with slip femoral epiphysis. But the most important thing is, we said it is characterized by excessive hip abduction as the legs swing forward. Therefore, the child is walking, but as he swings the leg forward, he will what? Abduct and circumduct the leg. This is characteristic of hemiplegic gait, typically observed in children with hemiplegic cerebral palsy, in some with limb length discrepancy, in some with stiff or restricted movement, such as juvenile idiopathic arthritis. Then they said children with hemiplegic CP, there are 4 patterns of hemiplegic gait. Just like the way we have in diplegic CP, we have the equinox. Hemiplegic gait also starts with equinox. Then we now, for the diplegia, we have what we call the jump, gait. Then we have the crouch gait. This one will also have 4 variants. The 4 variants are, we have type 1, type 2A and B, type 3, and type 4. Okay, the first one is, they said, for a child who is exhibiting hemiplegic gait, most especially if it is hemiplegic CP, they said there will be foot drop at what do you call it, swing phase, but there will be normal dorsiflexion arranged in stand phase. Therefore, when the child is circumducting, you are likely going to see the foot is dropping in the swing phase. Then they say this is the mild type. The mild type. That is, you only observe little circumcision with that foot drop. Then the second one, they say true equinox, excessive ankle plantar flexion in both phases. Therefore, in both gait phases, we mean in both stance and swing phase. They say true equinox, meaning that there is ankle plantar flexion on the affected side with excessive ankle in both phases. In both phases, both in swing and stand phase, you are likely going to see ankle plantar flexion. Then in 2B, they said true equinox, meaning that there is also plantar flexion, but this one can be accompanied by genu recurvatum, excessive hyperextension of the knee joint, plus limited flexion extension of what? Okay. So we are talking about the second one, true equinox, meaning that plantar flexion is stand phase, but this can be accompanied by genu recurvatum. That means excessive, knee hyper extension of the knee joint. And then there will be limitation in either flexion or extension at the knee, please, at the knee joint, in both phases. Therefore, the issue is when we have type 1 is the mild one, type 2 excessive, what do you call it, equinox. But the first one has to do with plantar flexion in both swing and stance phase. The second one, there is also plantar flexion in both swing and stance phase. But here there is what? Addition of what? Genu recurvatum. Then in type 3 and 4, we are talking about the hip joint. What happened to the hip joint? They said there is also true equinox. There is also plantar flexion. There is also knee jump deviation. But the most important thing is there is limited flexion or extension motion at the what? Hip joint in both phases. Here, now there is circumduction, but with limitation in either flexion or extension of what? The hip joint. Before, in the other two, the hip joint is okay, but this one, it has gone to the hip joint. Here we have true equinox with knee jump. They said there will be stiff knee, flex and internally rotated or adducted hip. Here, both the knee and the hip are what? Contracted, and they are limited. These are the 4 variants of what? Hemiplegic gait. The ones we normally see are the first one and second, what do you call it? The first one and then type 2A and B. We are only interested in what? The circumduction and what? The equinox. But they said we are likely going to see reduction in hip motion in the third one, and also reduction in both hip and knee range of motion in the fourth one, including the equinox. Cool? Meaning that in equinox is part of hemiplegic gait. The children are likely going to work on what? On their toes in all the 4 different types. Then we have seizures gait. They say seizures is as a result of hip adductors and medial hamstring spasticity. Hip adductors, adductor longus, adductor brevis, adductor magnus, gracilis, and obturator internus. They are the hip adductors, and then medial hamstring spasticity, they are the ones that causes. They say it is also caused by what? Persistence femoral anteversion. Yes, some people are not muted. Some people are not muted. Remember, some people are not muted. Okay, persistent femoral anteversion, meaning that inward turning of what? The femur. If it is not corrected, most especially in children with cerebral palsy, that are spastic, it will lead to what? One limb, the knee of one joint going over across the knee of the other joint as the child walks. They say child walks with legs crossing each other. Remember the difference between this and what do you call it, and bow leg. In bow leg, the child walks with the knee, maybe rubbing each other. Is that also? But in seizures gait, the legs what? May cross each other. But both of them, in bow legs, we said rickets may be a factor. Some, what do you call it, dysplasias may be a factor. But in this one, we have hamstring tightness and we have persistence femoral what? Anteversion, inward curving of what? The femur. Then we can now see this is the seizure gait. This one is not cross, it's not a rubbing, it's crossing. Go. One leg crossing over the other one. This is the seizures gait. Then we now have the antalgic gait. This is a serious issue. Antalgic gait is a painful gait on weight bearing. Even if it is an adult, he says, I cannot bear weight on my leg, I'm having pain, then it's a problem. Therefore, this is antalgic gait is always pathological. Something is wrong. Pain is the cause of antalgic gait. It is characterized by shorter step lengths. Child will not be able to, what do you call it, will not be able to open his leg very well to walk. Shorter stance time, yes. What usually happens is the child will only bear weight a little bit and relieve pressure on the leg. And we know what we mean by in antalgic gait. What is the common name for antalgic gait? We call it limping. Go? Limping, yes. If one is limping, what happens is he bears weight a little bit on the leg to relieve weight. The reason being that something is paining that particular child. It is characterized by shorter, what do you call it, stance time. That is characteristic of limping on one side of the body or one side of the painful lower extremity. It may be accompanied by what? Contralateral trunk lean with knee and what? In a patient with knee and foot pain. What they mean here is that if you have pain in one of the knee or one of the hip or one of the leg, will you bear weight on it? No. Usually, one will tilt his trunk such that he does not bear weight on the or bear weight on the affected side. He will just put like a little bit, pump, and then relieve pressure. Therefore, what they mean here is accompanied by contralateral trunk lean, trunk deviation away from where the pain is. That is very common. Therefore, when you ask a child to walk and you see the trunk is leaning towards the right leg, then there is problem with what? The left leg. Then I said causes may include trauma. The trauma may be on the sole of the foot. Probably he stepped on a what do you call it? On a nail or anything, or there is osteomyelitis somewhere in the leg because of the swelling and pain. The child may be unwilling to bear weight. Therefore, it may be an index of suspicion that, okay, why not do X-ray? Let's look at, is there any swelling? Can we compare the two legs? For how long has it started? Was there, what do you call it? Is there a history of fall? We ask so many questions. We touch the leg to feel if there is increased warmth. Probably there may be a pathological process. Is it an idiopathic arthritis, most especially juvenile rheumatoid arthritis? Does it affect large joints of the body and so many joints? Does it affect only one joint? All these ones, it requires a lot of suspicion. It may be observed in juvenile idiopathic arthritis. Those children may not always complain of pain, but it is something that what do you call it? Looking at antalgic gait is a painful gait. Therefore, it is also important. Then we now have ataxic gait. Ataxic gait. Here, when we say ataxia, we call it an unstable or unsteady gait. It is an alternating narrow to wide base of gait. Therefore, the child may assume narrow gait or walking. Then later, he would open the leg. Later, the gait will become narrowed and is unstable. It is observed in ataxic CP when the child has ataxic CP, and usually for children that have ataxic CP, it may be as a result of lesion to the cerebellum. Other condition affecting cerebellum, e.g. acute cerebralitis and posterior fossa tumor, may also lead to ataxic CP. Yes, I have managed a child with ataxic CP, but his own cause of CP, they said, is periventricular leukomalacia. Therefore, he has serious ataxic CP with cerebral, yes, what do you call it? Cerebral diplegia and ataxia. Therefore, his gait, the two lower limbs are not very strong, and he is not what do you call it? Very stable. Then they said it may also be due to sensory ataxia found in condition affecting proprioception, such as sensory modalities. But actually, this is more common in the elderly, where you have tabes dorsalis. You have it. It affects the dorsal column luminiscal system. The individual will only walk. If he walks at night, he has to be seen where his legs are because he has sensory ataxia because of loss of what? Proprioception. Yes. Then we should also be observant. In this case, where the child may not develop like those that underwent what do you call it, selective dorsal rhizotomy. Usually, the sensory nerve rootlets are being cut. The child may lose proprioception in the leg. The child may lose sensation. He may be like a child having sensory what? Ataxia. He has to be watching his leg because of loss of sensation. But this is a surgical procedure to relieve spasticity, but may leave the child with sensory related issues, serious ones. Then we have cerebellar ataxic gait, usually secondary to cerebellar injury. Therefore, apart immediately a CT scan is done, they say, this is a cerebellar injury. They said it is worst with Romback test. Therefore, shin to heel test, all these guys test, tandem walking, and all this. They said it's very, what do you call it? Finger to nose, all these guys, they said it is worse with Romback testing. Cerebellar gait initiation is normal. What they mean is that to initiate the gait, there is no problem. But coordination is broad-based, insecure, and wobbly. Okay, I think we are going to take some break. Going to observe prayer, then we come back like at 1:30. Okay, let me take some break. We come back after 1:30. Hello?
Okay, sir. Okay, sir.
Okay, let's come back after 1:30.
Okay, sir. Thank you, sir.
Thank you.
When are we coming back?
1:30.
Okay, sir.
Let me observe some prayers. When I was like, about introduction to gates. But I can get analysis ba. Yes. Kuma it's very common. Mutum ya zo da ɗansa ya ce ai yana tafiya a wannan. Da akwai wanda suke da normal, wasu kuma da are not normal.
Ki bari abu bai fara ba ina kokarin saki jini.
ma za su shiga ɗaukar hoto.
Zan mare ki ina jina masa nan. Dala ki masa nan. Ashe na je ko me na je na taba ne ma musan.
Babu ba na duba har fara
Ta shi kenan ku je ku yi alwala. Ka bari ba abin da zaka ji ban bai kama ba bace ma nan. Kun ji ba? Kun ji ko ba ku ji ba? Wai ba ku je kira sallah ba ko? Amma ba yanzu ba mene?
Amma ita kike gobe? Ita kike gobe?
Ba yanzu ba.
Gobe ya kike gobe? Me da in ci abinci?
Amma tuku je ku yi alwala. Je ku yi alwala.
Okay, we're all welcome back to from the short break that we had. Can you hear me? Hello?
Yes, we can hear you.
Okay. Please, can you hear me?
Yes,
Okay.
we can.
Yes, we talk about okay, we are on cerebellar ataxic gait. We said it's secondary to cerebellar injury, and it produced worst outcome with Rombach testing. And they said in this cerebellar ataxic gait initiation is not a problem. The child can initiate gait, but however, the coordination and consistency of the gait is what is the problem, and it's usually broad-based, insecure, and wobbly, meaning that cerebellar ataxia is a very worst type of ataxia. And we now move to Trendelenburg's gait, and I will say this Trendelenburg gait results from hip abductor muscle weakness. Hip abductor muscle weakness. If we know our anterior superior iliac spine, then just what do you call it, behind it, when you touch just behind it, around just immediately on top of the hip joint, that is where the hip abductor muscles are. They said the weight bearing on the ipsilateral side, if you ask somebody to do a weight bearing, like you want to check the hip abductors, if I stand and I face a mirror, if I stand on my right leg, the hip on the left side, if I stand on my right leg, meaning that my left leg is being held in the air, then the hip on the left side supposed to balance up. Then it is the work of hip abductor muscles on the right to balance the hip on the left. If I now exchange, I now stood on my left leg and I raise my right leg, then the hip on the right side is supposed to balance. If not, if it sags, then hello, sorry, 1 minute. Hello, Malali. To Malam suna ƙasa wajen da motocin mu suka faka sun kawo bacci. Eh, okay, ai suna nan kawai ka same su a wurin indai kana. Okay. Okay, sorry, somebody called my phone. Um, Therefore, we are saying I'm describing the way the hip abductor muscles work. The hip abductor on the right side stabilizes the hip on the left side. The hip abductor on the left side stabilizes the hip on the right side. And their action is called when an individual or when the child raises the leg, probably in the swing phase of gait. Therefore, when the child is on stance phase on the right, then the hip on the left side is stabilized by the hip abductors on the right side. The same thing when the child is on this, when the right leg is on the swing phase, then the hip on the left, what do you call it, on the hip abductors on the left side stabilize the hip on the right side. Then they said, now, what happened in Trendelenburg's gait? That is what the second bullet is saying. While weight bearing on the ipsilateral side, the pelvis drops on the contralateral side rather than rising as is normal during single limb standing. They said it is caused in conditions like leg calf patches disease. I think there was a time in this platform we discussed leg calf patches disease. It causes this condition we call slip femoral epiphysis, and then the calf patches disease is another cause of what do you call it? Fracture neck of femur. It's another cause of fracture neck of femur. It can also be observed in individuals with juvenile idiopathic arthritis that involves the hip muscle. Then it can also be found in children with spina bifida cystica if one hip muscle is affected, mild spina bifida, and in some individuals with spinal cord injury. That's the Trendelenburg's gait. Then we now have high stepping gaits. In high stepping gait, high stepping gait is a foot drop gait. We said gaits that occur as a result of injection palsy. These ones are gaits that occur as a result of lower motor neuron lesion, most especially sciatic nerve palsy. Therefore, we say it is characterized by weakness of ankle dorsiflexors. Remember, we said spasticity of ankle dorsiflexors, severe spasticity of ankle dorsiflexors, like tibialis anterior, it causes foot varus, in varus deformity in the of our children with CP. But here we have weakness of dorsiflexors. Weakness of the dorsiflexors meaning that when the child is walking, in the swing phase, the dorsiflexors are supposed to maintain the foot in mid position. The foot not supposed to drop down or go up. It's supposed to be maintained in in mid position. And then at heel strike, dorsiflexors supposed to stop the foot from slapping. Therefore, now we have where there is severe weakness, the initial contact with the ground is made by the foot, followed by the heel region. What they are saying is when a child has severe weakness of ankle dorsiflexors due to sciatic nerve palsy, when the child is to do heel strike, instead of the heel to strike is the foot because the stoop has dropped. Then they said in mild weakness, the initial contact is made by the heel. But what happened is the foot will now slap, pop on the ground. We call it what? Foot slap. But actually there is dropping of the foot in the swing phase and slapping of the foot on the heel strike. That is a high stepping gait. And then we said during swing phase, the toes may drag or catch. The compensation is high stepping. What happened is since the foot is slapping and the child does not have enough dorsiflexion to keep the foot in mid position at the swing phase, the child will end up doing what you call high stepping, raising the foot above the usual level. It is called excessive hip and knee flexion or body shift to clear the foot. Then we now give example, we say lower motor neuron lesion like spinal bifida injection palsy and peripheral neuropathies like Charcot-Marie-Tooth disease and Guillain-Barré syndrome all present with foot drop. Yes, and then you have some orthopedic conditions. These are very common when somebody has laminectomy at the back, probably because of collapse, disc collapse. Probably the patient has surgery. Usually, post-surgery, the patients with who had surgery because of back pain, they may end up having foot drop. Okay. And the last part of today's, the second to the last part of today's lecture, we want to introduce the types of gait analysis that we have. And though majority of the discussion on gait analysis types and everything will be done next week, but we felt that we should introduce the types of gait analysis that are available. We have, introduction. They said gait analysis involves the quantitative evaluation of various gait parameters such as joint kinematics, kinetics, spatiotemporal variables, and muscle activation. In essence, when one is discussing gait analysis, you would have to look at various gait parameters, stride length, stride width, both spatial and temporal gait parameters, the phases of gait that we discussed today, it has to be discussed in total. Then other parameters such as joint kinematics. What are joint kinematics? What are the kinetics of gait? Is part of what should be discussed. Then we now have muscle activation pattern, and this muscle activation pattern has to do with which muscle is actually activated, which muscle is not activated, which muscle is weak, because that will, and then this is done, this is the work of electromyography. It's also part of our what we call gait analysis. They said gait analysis provides indispensable tool for stimulating and understanding human movement dynamics. Therefore, whenever there is change in gait pattern or there is improvement in gait pattern, gait analysis should be able to say this is the dynamics that occur. Then the next is we have the types of gait analysis. We have observational gait analysis. Usually, observational gait analysis is the gait analysis we do in the clinic. We ask the patient, can you walk around? They say, oh, the patient is having antalgic gait. Oh, the patient is having knock knee. The person is having what do you call it? Bow leg. The patient is having foot drop. This one's what we call observational gait analysis. Then we have footprint method. Is the one we use paper on ground, or you ask somebody to dip his leg in a paint. You calculate the stride length, stride width, stride velocity, cadence. All these ones we use this to assess as spatiotemporal gait parameters, which will be discussed in total next week. Then we have instrumental gait analysis. This is the cornerstone. Instrumental gait analysis is the cornerstone of gait analysis now. Gait analysis has become sophisticated. We use motion laboratories to assess. Some of them are doing it as business. Therefore, you send your patient, they do all the analysis, they tell you. Usually, it can be used to direct surgery, most especially multi-level surgery. Then you have component of instrumental gait analysis. Here, we're going to look at 3D, 2D to 3D motion gait analysis. We have instrumental maths, like gait right and all these stuffs. Then we have marker gait analysis, pedography, and electromyography. Hello? Okay. Okay. Magana malam yana ofis. To shi kenan ni ma yanzu na kusa karewa. Ba ni muke ai. Yau zan yi yau rashin nake. Yau rashin nake. Okay, I'm back. We have the 2 and 3D motion analysis, instrumental gait math. We commonly call them gait right. There are different types of companies that produce them. They measure the pressure, and we have marker-based gait analysis. Involves putting optical markers in the body of the individual as he walks. Pedobarography has to do with pressure on the legs of the patient. We're going to discuss that next. Then electromyography. These ones are the cornerstone for instrumental gait analysis, meaning that part of what we will discuss next week, we have observational gait, footprint method, instrumental gait analysis, which involve all these guys. Then we now have the last part of today's lecture. We are going to look at factors influencing gait pattern. If you, as a physiotherapist, you want to assess the gait of an individual, how do you accurately get it? What are the factors that influence it? The first one, we have footwear. Therefore, if somebody is wearing high heel, if somebody is wearing boots, if somebody is wearing slippers, and if somebody is not wearing anything, what will the gait look like? Therefore, they said it causes gait variability. Some footwears can cause increase in hip movement, which results in long stride length, while some may reduce the stride length. Therefore, usually in gait analysis, we don't allow somebody to wear foot. Then we now have fatigue. If somebody becomes tired, all the energy is depleted. It's going to decrease his working speed, probably the cadence and everything. Fatigue may give you a wrong what you call analysis. Use of brace or AFOS, ankle foot orthosis. If somebody now has rigid ankle foot orthosis that does not allow either the knee joint or the ankle joint to move, then definitely there will be loss of heel strike, there will be loss of toe up. The child will just be walking with flat foot because he has POP in the leg. Therefore, that may affect your gait analysis. Then we have speed of walking. If somebody is walking at a normal speed, the gait will be different than if somebody is running or if somebody is walking fast. Therefore, the gait is likely going to change. Then we now have medical conditions, pain, arthritis. These are part of what we discussed since morning. Pain, arthritis, neurological conditions, CP, head injury, sciatic nerve palsy, spinal muscular atrophy, myasthenia gravis, Duchenne muscular dystrophy. All these guys, they are medical conditions. All of them can affect the gait of the child. We talk about age. Remember, we said the age changes, what do you call it? The gait pattern changes with what? Age, most especially in children up to the age of 8 years. Therefore, there may be improvement due to maturation of the neuromuscular system. They said age one is one, and then we said muscle strength. Age is one of the factors that influence gait pattern. Walking depends on muscle strength, which is gradually changing as the child grows up. Therefore, variation in muscle strength can affect gait. Therefore, remember we said there are some, let's say, even deformities in the leg, like let's say the flat foot, the what do you call it, genovalgum. They are due to laxity of joints. As the child grows, the ligament tendons become strong. The gait is likely going to change due to the strength of these what do you call it, tissues. Then we have deformities in the lower limb and foot. This is the last one. Therefore, a child that does not have deformity and a child that is having knock knee or bow leg, their gait is likely going to be different. We said in conclusion, we have gait is a skill. We said that is learned, that improves with time, and then it's a characteristic of human being. And then we said gait pattern is simply the manner or style of walking. We said gait in children changes with increasing age up to 8 years, and it can be affected by neuromuscular and orthopedic conditions. Thank you for listening. By God's grace, next week we are going to look at we are going to dwell into gait assessment. Thank you very much for listening. Okay, comments, contributions? Hello. 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 Hello.
Hello. Hello, good afternoon, sir. Hello. Hello.
Okay, I want
Hello. Thank you. Thank you for the presentation, sir. Good
Okay,
afternoon.
thank you.
My name is Welcome. Please, I want to know about the case of arthrogryposis.
Yes.
I had in one of my research, and I read from some of them about absence of part of the bones in the feet, so
Yes.
that makes them to not want to bear weight on the feet. So I wouldn't know. Am I right in all cases of arthrogryposis, or what can we say about how it affects their gait? Thank you, sir.
Yes. Actually, in most of these conditions, it depends on the severity of the conditions. Therefore, some may be amenable to gait retraining. Some may you want to only maintain the gait alignment. It depends on the presentation. Mostly, the hallmark of our treatment as physiotherapists is to make sure that the patient is able to walk. Therefore, within the limit of what the patient presents with, we can do gait assessments. It depends on the presentation. We can look at what is the deficit in the gait. Is it strength that is needed, or there is a congenital absence of a particular component of a joint? Then if there is congenital aspect of a particular component of the joint or the joint surface that may not allow the patient to be able to bear weight, probably we have to assess the patients together with the orthopedic people and see what they can do. Usually, in most of the cases, except if you have a particular case where the individual has a particular presentation that may allow him to bear weight on the legs. But the most important thing is, depending on the presentation, the ultimate aim is, if the gait assessment is going to help the patient bear weight based on your assessment and based on what the patient presents with, then we can go ahead. It should be part of it. Remember, even for children with CP, there are children that are ambulant. From your assessment, this child, with effort, this child is going to walk. There are some that it will take miracle for them to be able to walk. Those people that will be able to take some steps, then you can go ahead, do all the assessments, see how you can best help them to achieve that. I think it depends on presentation. Thank you. Hello?
Hello, sir.
Okay.
Sir, in the case of, yeah, thank you, sir, for the response. In the case of children with cerebral palsy, in this case, that probably like the case of diplegia that you mentioned earlier in the presentation, is it advisable to stimulate the, for instance, after analyzing and realizing that the knee extensors are probably the weak muscles that are hindering the ambulation or the walking? Is it advisable to use any means of stimulation, and then mechanical stimulation or electrical stimulation? Sorry. So in this case,
Yes,
thank you, sir.
actually, there are some conditions that specifically there are some treatment methods that work best for them. You see, for a child with cerebral diplegia, most especially the one with crouch gait, the major problem is hamstring tightness. Therefore, if the therapist is not able to release the hamstring, then it has to be released surgically. That hamstring tightness is one big factor in these children. As part of their routine treatment, when physiotherapist comes, he must learn to stretch the hamstring. Hamstring tightness is a very big case. You can increase the strength of quadriceps, but the major issue is they will not be able to contract against a much stronger, tight hamstrings. And another issue with them is that you also need an orthotic device. We call it ground reaction, ankle foot orthosis. Ground reaction ankle foot orthosis, we call it GRAFO. Therefore, even when you are stretching, even after you must have stretched the hamstring, and you exercise the quadriceps, you can do electrical stimulation if it works for the patient. But actually, working on the hamstring will allow the knee joints to move freely. Therefore, that will even allow the quadriceps to be able to contract when you are exercising the quadriceps. Therefore, the most important thing is work on the hamstring. That is the most important, such that the quadriceps will be able to strengthen. Even if you are given the exercise, the quadriceps will be able to have some strength. Then you can add it. Functional electrical stimulation can also be added. But remember, the child should have grapho fitted to the leg. One big problem is with them is that there is excessive dorsiflexion. That excessive dorsiflexion is like the tibia is almost approaching the foot because the leg is in excessive dorsiflexion. That particular grapho is the one that will separate the tibia from the foot, meaning that it would enable extension of the ankle joint, such that even if you want to stand the child, it will be possible. I think grapho plus hamstring tightness before you now begin to look at strengthening of the quadriceps with functional electrical stimulation. Thank you very much. Hello?
Hello, sir.
Yes, I'm with you.
Okay, sir. Well done, sir, for the presentation.
Thank you, ma'am.
Sir, I managed the patient with the lower limb. It was externally rotated.
Yes.
It's so even when though they stopped coming, the ankle is still externally rotated despite everything we did. I tried, though he also had foot drop. It was a case of injection palsy. He had a foot drop, and the entire lower lip was externally rotated. Despite we stimulated the tibialis anterior we still were not able to get, as in make it, as in the leg to be correct. We were not able to correct the leg per se.
Yes.
So what can we do for a patient like that?
Yes, actually, there are some instances where physiotherapy alone, most especially if the child is left to keep working with external rotation of the leg, at times he has to be seen by orthopedic surgeon, whether there will be transfer of one muscle group to another such that it will facilitate internal rotation, most especially the internal rotation. Is it from the hip?
Yes.
Yes, usually at times, and I think probably the presentation is, I think probably they did not present to physiotherapy department on time.
Yes, yes, they did
That
not.
is where yes, if a patient is not sent to us on time by the doctors, or the patients did not even come to the clinic, then we are interested in, okay, foot drop, and at the same time facilitating internal rotation of the foot. And then the only way we can facilitate internal rotation, most especially if the child is up to 6-7 years and he can, he can respond to command. If the child can respond to command, then you can always facilitate internal rotation actively by giving him some activity like staircase climbing, making sure that the leg, at times what we do is there is what you call queuing. You know what queuing is? We draw a line. I will now say, okay, this is the front of your leg, most especially if you can follow command. As you move, don't allow the leg, your leg. Yes, the line of progression is this. I draw a line. I will say, okay, don't allow your leg, most especially the tip of your toe, the big toe in the leg, to deviate from this line.
Yes.
Actually, we keep doing this, we keep doing that. Even if we are climbing stairs, we now draw that line on the stairs. Okay, this is the first stair. Yes, you can see the line of your the tip of your, what do you call it, toe is facing. The tip of the toe should not face away from this line. We kept doing it. Then at times we help the child. We say, okay, let's do squatting. We do a lot of squatting with the leg. At times we kick. Yes, we kick ball in front of the child, and we said, okay, kick, but we want it to be kicked in such a way that the leg will be turned inward. Okay. Now let me give you an example. I have two legs, right and left, and I want the child to kick the ball such that it will kick from that where the right leg is towards the left. Then that will facilitate internal rotation. And at times, mat exercise. If you are on mat, you hold the child's leg and you ask him to rotate. He should be able to rotate the leg actively. Then through that, probably we now exercise the internal rotators of the hip joints. But where we have problem is if the child cannot follow instruction. When the child cannot follow instruction, whatever you give is passive, then you are not likely to achieve anything. But the bottom line is most of the children that develop external rotation of the foot as a result of foot drop, they may have stayed home long, but they were not sent to the therapy department on time. Then we are left to manage two things. We manage the foot drop, and we now have to crack our brain to see what will happen to the particular compensation that now occurred, external rotation of the foot. At times where we cannot actually achieve that, we have to invite, or we have to have a talk with the orthopedic surgeon.
Okay.
Hello,
sir. Thank you so much, sir.
Thank you.
Good afternoon, sir. I have a question.
Hello, sir.
Okay, good
I
afternoon.
wanted to respond to the.
Okay, sir, I have a question. Thank you so much for your presentation. Can you hear me?
I can hear you.
Okay, I have a question about toe walking, as we usually see with children with cerebral palsy. So, sometimes we see that they have TA contractures, and some PTs end up doing serial casting, like using the POP to stretch the TA and being able to achieve some range there. But when do we draw a line between continuous use of POP and then referring to the orthopedic surgeon for either tendon release? When do we consider that?
Yes, when you did the serial casting, you see the last resort for management of these guys is the serial casting. because we don't do botulinum toxin injection, all these ones that will relieve a lot of spasticity. Therefore, the last resort we have as physiotherapists is to do, to do serial casting. If really the serial casting cannot achieve enough lengthening, then physiotherapists would have to release the patient for, surgical release. But if you are able to achieve it with serial casting, remember, the issue boils down to, do we really prevent it? Let me give you one example of a patient that left Nigeria and went to Egypt. What they did immediately, they fit him with cock-up splint in the upper limb. Up to the time they finish managing him and he comes to Nigeria, he did not have that flexion contraction in the upper limb. That flexion synergy did not affect him. Therefore, in our case is when we manage patients, we know that these patients are going to develop equinox. Therefore, rather than fitting them with ankle foot orthosis, most especially if they can be using it as night splint, such that they will not develop it, we now keep managing them until when they finally develop it, or when the patient did not even come to the physiotherapy department until he has developed TA tightness. Then we now start with stretching, sustained passive stretching, massage at times, some will use cryotherapy, sustained passive stretching, standing, squatting to stretch it. If it does not work, then we now say, okay, why not do serial casting? If at all we do serial casting and it does not work, the last resort is we either send him or we look for where they will do botulinum toxin injection so that everything can be released. But I think serial casting is the last resort to stretching it, because you can stretch it for as long as 1-2 weeks, then you now break it and stretch again. If it does not occur, release it to orthopedic surgeon. Thank you very much.
Thank you so much, sir.
Okay, thank you.
Hello, sir. Please, I have
Hello.
a question. And
Okay.
I wanted to respond. Thank you so much for your presentation, sir. It's very timely, and I have a few pediatric patients we are managing with lower limb conditions. So I wanted to respond to the previous commenter, the lady who asked about the patients who has external rotation. And I wanted to suggest that of the hip. Yeah.
Okay.
They should check the hip adductors as well. That you can also hello sir. That you can use that. You can use that to help train the external rotators by giving the patient bridging exercises. Maybe you put a ball between the two knees and ask the patient to hold and adduct and do the bridging exercises. You can also put the ball in between the foot and ask the patient to push. That's if the child is old enough to understand and follow command. But I believe that from age 3-4, they should be able to do that. So you can also use a ball between the thighs, a ball between the foot to help kind of like train and strengthen the hip adductors to also help correct that external rotation that you're seeing. I don't know if you can add that to whatever management plan and see if there's an improvement.
Yes.
And my question.
Yes, I agree with you.
Okay, sir.
Okay.
Okay, my question has to do.
The issue. Okay.
I'm listening, sir.
Okay. No, continue, please.
Oh, okay, sir. My question also has to do with crouch gait walking. I actually have a patient that came to us, and when we're trying, she came when the child was about 7.5. And when we quizzed the mother to try and find, immediately I saw the child, I felt, okay, this is spastic diplegia manifesting. Maybe as the child grew, she developed crouch gait walking. And the older she grows, the heavier she is, the more.
Yes, usually they are very heavy.
Yes, because that was the first thing I identified with that child. But the challenging thing for me was the mother was told, I don't know, she told me she was told it was spina bifida. And I disagreed with that because I looked at the child, I looked at the lower back, and I didn't see any evidence of the child having had any form of spina bifida. not even the occulta type. I told her that I feel this was cerebral diplegia.
Diplegia, yes.
Yes, sir. But the challenging thing is that the patient now went for to see an orthopedic doctor, because I felt that we were trying what we can to maintain range of motion, but I felt the child needed to go for tendon release, especially because the hamstring tendons are so tight, you can't even extend it. So
that is the wahala in that thing.
Yes, sir. So when when she went for that particular visit with the doctor, they were told to do an MRI and a CT scan. Part of and they did X-rays as well, and they did a lot of. But what was surprising to me was that when they did the CT scan, they found nothing, no focal site of injury or anything in the brain. All the scans were clear. So I was now wondering that what could have led to this crouch gait if it's not if there's no injury to the brain, if we can't find any focal mass or anything that could have caused it back when the child was born. And so I quizzed the mother a bit more. She said, she noticed that the child did not walk on time until she was 1.5. And when she started walking, she was toe walking. So my question now is, could idiopathic toe walking lead to crouch gait like that if it wasn't properly managed when the child was younger? So that's my question, sir. Because I'm trying to figure out what exactly.
Thank you. Actually, the question is very, very clear. The question is very, very clear. Let's see, regarding your first contribution, I thank you for yes. Actually, we as physiotherapists, we need people that will add to the repertoire of all the ideas that we have. You know, one thing is specifically hip rotation and hip adduction are two separate things, but the adductors can also stimulate the hip rotators. Therefore, in a way, the child will be able to have maximum control. That one can also be added. Then concerning the case of a child with cerebral diplegia who has no any focal neurological damage, I have managed a child who developed encephalitis. She is very bright. She was the best student in the what do you call it, in her JS exam in her school. Very bright, but she developed cerebral diplegia due to encephalitis. Therefore, when the encephalitis is gone, everything looks normal, except if you know the history that she had encephalitis and she was taken to ICU. But everything, because there is no structural damage in the brain, it is just an inflammation due to an infection.
Okay.
Probably part of what we need to know is we ask them, has the child been hospitalized before? Yes, probably the child was, yes, because the child was feverish and he was hospitalized, and is probably it may be encephalitis that caused it, because I was also surprised when I say, there is no focal neurological damage, but the history can be traced that she has encephalitis and she has to be admitted even in ICU, and she develops cerebral diplegia. That is one. And the second thing is, remember the classification of hemiplegia and diplegia. All of them start with equinox. Remember, even the child with jump knee. You know, we say younger diplegic start with jump knee. All the legs are what? All the legs are on toes.
Toes, yes.
Yes. Therefore, when a child comes, all the legs are on toes. It is possible that the child is having Duchenne muscular dystrophy, or probably if it is a male child, if it is a female child, is another thing entirely. Therefore, anything can happen. Therefore, I think you are also we are not far from saying that people should always be mindful that a child who walks on the toes, two toes, is likely being the first sign of cerebral diplegia, because it appears in crouch gait, which is the beginning of what do you call it? It appears in jump gait, which is the beginning of crouch gait, then it may be something else like the muscular dystrophy. But in that case, it has to be a male, and then the calf will definitely be hypertrophied.
All right, sir. But this patient is female. But
yeah, this patient is female, then definitely it must be something that affects the brain. It may be an infection that causes it, but the infection is normal, but there is no structural damage.
Okay, all right. Thank you, sir, because I was really confused. Thank you so much.
Because you may read about encephalitis and probably cerebral dysplasia, because we had a case like that. And the student is very bright, only that her walking, and it affects also her speech.
Okay.
All right, we have Rabiatu. Thank you. Rabiatu.
Hello, sir. Hello, sir. Okay. I have a question, sir. Good afternoon.
Okay.
And
good afternoon,
thank you for wonderful presentation.
Thank you, sir.
Yes. When you are speaking, you say something about blunt disease, and it caught my attention because I've had the patient. I think currently, initially when I saw this patient, it was when he was 7 years. But later, the mother brought him again, saying that he's having pain on his knee. If I could get a knee brace for him. So I said he should bring the child. So when they came, I now checked the child's weight, and he's wearing 104. Understand? And yes. I asked the mother the age. He said he's 14 years old.
And it's 104.
Okay, 104. Honestly, and when I checked the knee, as in, when I see him walking, he was totally off, as in total, as in exaggerated knee. Let me say, genovarus. So I was telling the mother, it was initially when I complained about the issue, when I saw the patient in the first time, the mother said is hereditary, that the father had such a issue when he was growing up that he's going to correct. I said, okay, let's wait. Yes. So now on seeing this particular thing, I noticed this is the condition the child is going through. Now, I want to know what are the management process? Do we actually need orthopedic surgeon? On how is this particular patient meant to be managed, going by the weight and every other thing? Thank you.
Yes, based on what she said, we talk about the normal physiological valgus and varus. Therefore, probably she is waiting for 3 to 6 years and for it to strengthen. Now, probably the weight does not allow it to strengthen because the weight is more than what the joints of the child can hold. Therefore, the best option now, because even if it is physiotherapy, you want somebody to do exercise to lose weight. By the time you finish the exercise session, the joint must have been damaged. Therefore, I felt that he has to see a nutritionist.
Okay.
The nutritionist, the orthopedic surgeon, and physiotherapist will now have to sit down and plan on what to do. With the physiotherapist, the only way we can help the individual to lose weight is for him to be doing a lot of exercise. But based on the mechanics of the joints now, can the orthopedic surgeon advise, is there a lot of friction and erosion in the joint that frequent exercise can really lead to further damage to the joints? If they said yes, then meaning that we can do the exercise, but he has to undergo surgery to correct it. Then later, after that one, after the surgery, he has to do some nutritional adjustments. Then we now continue with the therapy when the weight is reduced a little bit. But it's central. Weight is there, but weight actually leads to further damage of joints. Therefore, adding wearing a brace will never take away the weight of 104 on a 14-year-old child.
At all.
The only thing that it can just provide support. But one thing is frequent movement and exercise will help reduce weight, but may end up damaging the joint if the joint is already eliciting a lot of pain. Therefore, assessment of the joints and advice from the orthopedic surgeon, and based on your clinical assessment of what do you call it? Then what I'll ask is, does the pain increase with motion?
Yes, yes.
You know, it's part of what physiotherapists will assess.
Yes, yes.
And then yes. And another thing is, does he have muscle weakness around the joints?
Okay. There's no muscle weakness, but just the pains. Once
Yes.
it's active, the pains come.
Yes, and then does he trek for a long period of time, as in, he always use something as means of transportation?
Okay. Yes. Okay.
If he use something as means of transportation, it's not easy for him to walk. Definitely giving him weight-bearing exercise may not help him. Probably when the orthopedic surgeon sees the joint, then we now come and prescribe non-weight-bearing exercise for him. Like, let's say, bicycle ergometer exercise.
Okay.
Yes, non-weight-bearing exercise, most especially because of the pain. Then, but the orthopedic surgeon also have to see the possibility of the exercise not further damaging the joint, because of probably there is subchondral sclerosis, there is erosion of the bone, such that they will not come and say physiotherapy has damaged the joint again. But majorly is a good candidate for non-weight bearing exercises. Probably when it comes to the clinic, rolling exercises, let's say upper limb exercises, then weight bearing exercise, but non-weight bearing exercise, but weight bearing exercise like walking on treadmill, I doubt much if they will help him, because they will end up damaging the joint again.
Yes. Exactly. Okay.
That is my take. You can have a discussion with a nutritionist and orthopedic surgeon, look at the x-ray, then come around with what you can do for the patient.
Okay. That's very good. Thank you so much, sir. Then another thing that I wanted to, another thing that I wanted to ask, this issue of muscular dystrophy.
Yes.
And you know, some of the patients present with toe walking, and the TA is always very, very tight, that is difficult for you to break the attention that the person is having at that region. So I want to know what are the management process of this particular case.
Yes, actually, you know, when you stop them from working on toes, they are not likely going to work again.
At all. Yes.
Yes. The weak trunk muscles and the weak gluteal muscles cannot support the trunk. Therefore, what happens is we use night splints.
Okay.
Therefore, you can use, you can stretch the hamstrings. It can just be daily something. You apply a rigid ankle foot orthosis that will stretch, and then he will sleep with it. Tomorrow stretch, he'll sleep with it. The mother must learn to do it. Then that will help the child. It's like on daily basis, he sleeps with it. Therefore, in the morning, they remove it, because without it, the child cannot work. Then gradually, you will now begin to see changes. But if you do not use it as nice splint, then it is going to affect the child's ability to work.
Okay. Thank you so much, sir.
Thank you very much.
I'm so grateful.
Thank you, sir. Thank you, sir. Rabia Tugidado, your hands are up. Rabia Tugidado Aminu. Okay. In the absence of further comments, I have one ceremony that I'm to attend by 2 o'clock. I want to thank you for listening and for your comments and contribution. Until we meet next week. Thank you very much. Okay, Nina Holiday.
Thank you, sir.
Thank you.
Thank you, sir.
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 Wait, we first say thank you. You learn from me.
Sir, thank you.
Thank you, sir.
Thank you, sir. God bless you.
Move forward. Let's talk about that. Bye.